The how of making the Humble Ultrasound Biometer nearly equivalent to the mighty optical biometer. What is bread and butter of ophthalmology? It's cataract surgery, right? I beg to disagree. I think the bread part of it, yes, is the cataract surgery. But the nice buttery flavor comes from good ocular biometry. Because if the lens is wrong, then the patient is not happy and neither is the doctor. Let's go to the history a little bit. Before 1980, we were using standard power lenses or IDEM lenses. In 1980, a machine, A-scan, ultrasound biometry came into existence, and so did the SRK2 and modified SRK2 formula. But it was nearly accurate, not very much accurate. In the 1990s, generations of IOL calculation formulae came into existence to get it to be more accurate. In 1999, optical biometry revolutionized by having accurate results. It had extremely distinct practical advantages of being easy and fast. But it had one extremely big disadvantage, that is, it was very pricey. It still is very pricey. So what's the solution? What do the underpaid, overworking ophthalmologists do to get nearly accurate results? We go back to ultrasound biometry. Ultrasound biometry can be done two ways: contact biometry or immersion biometry. Contact biometry, I'm very sorry to say, is not really relevant in this age and era. Why? Corneal compression leads to unpredictable errors. Our patients deserve better. But to make it relevant, only way to do it is do it yourself. Surgeons have to do it by themselves. But even then, despite doing it by yourself, it's very difficult to hit the bullseye or even get close to the bullseye in such a case. So what's the solution? It is immersion biometry. We all know immersion biometry is the better technique. Reasons why it isn't so popular: it has a relatively long learning curve. It is quite hassled. We need time to prepare, and the attitude is old is gold. But in this instance, it isn't. So immersion biometry has this Prager shell with a column of saline in it. So the probe never comes in actual contact with cornea and there is no corneal compression. Both the readings of contact and immersion biometry look similar. Only the probe and cornea are together in contact and they are separate in immersion biometry. So how do we do immersion biometry? We get the patient in supine posture. We connect the 10 cc syringe with saline to Prager shell. We put the Prager shell on the anesthetized cornea of the patient. We fill the Prager shell with saline. We ask the patient to look directly into the light that is coming from the probe, the red light. So in this patient, we ask the patient to lie down. We put the Prager shell in the anesthetized cornea and fill the saline. Automatically, readings are obtained. The reading should look something like this. They should have 5 spikes of maximum height, 1 set of descending spikes, 90-degree rising for each peak, 2 equal length spikes, well-defined scleral peak, standard deviation of less than or equal to 0.06. Sources of errors and its elimination. Make sure the mode is confirmed and confirm a constant for that particular mode. Always perform in both eyes. Difference between the two eyes should be less than or equal to 0.3. The velocity of the lens, especially in pseudophakic mode, should be according to the lens that is already placed inside the eye. Use appropriate formulae for IOL power calculation. And the new player in the block, that is Barrett's 2 IOL calculator. Just put the IOL calculator on Google search and this page will be displayed. Fill the parameters and it gives up to 99% accurate results. Never forget the sweet spot for 80% of the patients, that is monofocal lenses, is -1 to -1.50 diopters of spherical equivalent. They can see distance as well as near quite comfortably. So if optical biometry is accessible, yes, use it. But if not, immersion ultrasound biometry with appropriate formulae is a very good alternative. Please use it. Thank you for watching the video.